Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Cardioprotection and Safety of Dexrazoxane in Patients Treated for Newly Diagnosed T-Cell Acute Lymphoblastic Leukemia or Advanced Stage Lymphoblastic Non-Hodgkin's Lymphoma. Report of the Children's Oncology Group Randomized Trial POG 9404 by Asselin et al. My name is Eric Chow, and I'm an Assistant Professor of Pediatrics at the University of Washington, Seattle Children's Hospital, and the Fred Hutchinson Cancer Research Center in Seattle, Washington, USA. I'm a pediatric oncologist and direct the Childhood Cancer Survivor Program here. Dr. Asselin and colleagues are commended for bringing to light some long-awaited results from one of the few large, randomized pediatric clinical trials of Dexrazoxane. Their study consisted of over 500 T-cell ALL and lymphoblastic lymphoma patients, largely treated in the late 1990s, who were randomized to receive or not to receive Dexrazoxane as a cardioprotectant. All patients were prescribed to receive 360 milligrams per meter squared of doxorubicin. A second randomization examined the efficacy of high-dose methotrexate in reducing relapse, particularly central nervous system relapse. Although their cardiac data were limited largely to the first 3 years after diagnosis and also limited to a subset of the entire study population, about 300 of 500 patients had baseline echocardiograms recorded and 170 had echocardiographic data at 3 years. Those data suggest that Dexrazoxane was effective in minimizing adverse echocardiographic changes. Importantly, the number of patients with echocardiographic data appeared similar between the Dexrazoxane and non-Dexrazoxane study arms, and their clinical and demographic characteristics did not appear markedly different from patients without echocardiographic data. Thus, there is no reason to believe that the original randomization would no longer be valid. Based on data from over 20,000 childhood cancer survivors from the Childhood Cancer Survivor Study, the National Wilms Tumor Study, the St. Jude Lifetime Cohort Study, and the Dutch Emma Children's Hospital Cohort, a hypothetical teenage boy treated with 360 milligrams per meter squared of doxorubicin in a study our group published in JCO last year can be predicted to have a 2 to 3% likelihood of developing clinical heart failure by age 40, which would still be more than 10 times the expected risk among same-age siblings. Based on unpublished childhood cancer survivor study data, individual risk for clinical heart failure by age 50 for the survivor described above could increase to be about 10% by age 50. Data from large cohort studies have consistently shown that after one's original cancer and any second cancers, cardiovascular disease is the most common cause of excess serious morbidity and mortality among survivors of childhood cancer. Thus, having an effective method of cardiac protection is exceedingly attractive, assuming that anthracyclines and related drugs will be integral in pediatric treatment protocols for the foreseeable future. The Dexrazoxane data, while already solid among adult cancer patients, appear to be increasingly persuasive among children, as measured by short and intermediate-term surrogate measures such as troponin elevation and echocardiographic indices reflective of pathologic left ventricular remodeling. In addition to the new data presented by Asselin and colleagues, similar findings at 5 years from diagnosis have been reported by Lipschultz and colleagues from Dana-Farber Leukemia Consortium, as published in Lancet Oncology in 2010. Reasons for not adopting upfront use of Dexrazoxane include concerns about interference with concurrent chemotherapy, induction of second cancers, and added hematologic and other acute toxicity, given that Dexrazoxane is also known to be a weak topoisomerase inhibitor. However, the preponderance of evidence would suggest that it does not significantly interfere with chemotherapy efficacy and that any second cancer risk is likely overstated. This study by Asselin and colleagues, as well as a recent National Death Index linkage study of POG 9404, and prior Hodgkin lymphoma studies, that is POG 9425 and 9426, did not show second cancer mortality to be increased among Dexrazoxane-exposed patients. Asselin and colleagues also discussed similar data from the Dana-Farber Leukemia Consortium and administrative data using the Pediatric Health Information Systems, which did not show Dexrazoxane to be associated with a significantly increased risk of second cancers, specifically secondary acute myeloid leukemia or myelodysplasia. There remains some data in the pediatric Hodgkin lymphoma treatment setting with its greater reliance on topoisomerase inhibitors that the randomized addition of Dexrazoxane may be associated with more upfront hematologic and infectious toxicity. However, this was not observed in the leukemia and non-Hodgkin's lymphoma patients treated by Asselin and colleagues. Other cardioprotective strategies, such as using alternative formulations of anthracyclines, such as potentially less cardiotoxic liposomal formulations, or post-treatment introduction of beta blockers or ACE inhibitors to minimize pathologic cardiac remodeling, remain under study. At present, the evidence supporting those strategies appear less mature than that for Dexrazoxane. In summary, the study by Asselin and colleagues adds to the growing evidence that Dexrazoxane may have an important role in ameliorating important cardiac late effects in childhood cancer survivors. As the authors mentioned in their paper, the Children's Oncology Group is engaged in a current study to prospectively ascertain cardiac health in these previously randomized patients who are now 15 to 20 years post-diagnosis to hopefully definitively establish the long-term efficacy of Dexrazoxane. In the meanwhile, and based on the known evidence gathered to date, clinicians should carefully weigh the potential benefits and costs of using Dexrazoxane among their patients receiving known cardiotoxic therapies. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.